Okay, moving on.
All right. So importantly, I think that uncertainty after this exam is almost universal. Um, well, you're taking this exam, it also feels very different from previous exams. So in general, just try to remain calm and keep going, just forge through. If you're really stuck on a case and you're worried you might not get to other cases in the section, you can skip a case, but you cannot return to it, and it will count against your final score. So just keep that in mind. Um, and interactions with examiners, they're going to vary. They are people with different personalities. So some may kind of help move you through along a case, and others may not say anything at all. Don't second guess case content. It may be that simple or straightforward, and it's possible that the same topic may be touched upon twice. So just keep those things in mind, that all the uncertainty you're feeling is normal. And Nora's going to take it from here. She's going to tell us about some resources and study tips.
All right, so we are going to review some of the available resources to help you study. So, the number one thing to remember is that you already know everything that's on this exam. This exam is very clinical. It's not the minutia that's on the written exams. The hard part about this exam is learning the format and structure and forcing yourself to, practice doing that to kind of be able to walk through these cases without any prompts. So that being said, the resources are broken down into three different types. So we have books, online resources, and in person. So books, I think Pemberton was the one, when I was studying at least, that people used the most. The version then only had about 60 cases. I think the one now has more like 130 cases. But in my opinion, the more cases, the better. And I mean, I went through Pemberton multiple times. The Will's Eye Manual, as you all know, it's not a board prep tool, but I did find it helpful for reviewing diagnoses and differential diagnoses. So I did find that helpful early in studying to kind of flip through the Will's Manual. Luviano is another case book that's available as well. And then, obviously we're biased, but OphthoGenie is one of the online resources. We have 200 interactive cases and a study bank with the library of cases. And I know some of you are users, some of you are not. We can do a demo towards the end for anybody who wants to see that. And then Optho questions, we all know from OCAPs and written boards. They do have a oral board prep tool. From what we've seen, it's mostly videos of someone speaking like answering the case, which I feel like is not as helpful. You really need to force yourself to do it. Listening to someone else do it is not really gonna help you that much with the actual exam. Eye to Eye Board Review is a tutoring service. I don't know the exact price. They don't have it posted on their website, but you can purchase a certain number of sessions to do kind of one-on-one tutoring. In-person courses like Osler or the University of Colorado, in our opinion, are helpful, but are more a supplement to your studying. They are one-time sessions. At least when we took it, the Osler course was the week before the exam, and so it's not enough time to learn all the material. It's kind of a good supplement to what you've already done yourself. So study tips, I think the most important things are talking out loud when you're practicing cases and timing yourself. I think this is where smart people get into trouble with the oral boards because they know the content. You guys all know the content. It's really learning how to take this exam. So this really needs to be active learning. You're not just going to be able to like read a textbook and study. You need to really go through the cases and talk out loud and time yourself. In general, it's helpful to study, start with your weakest subject first so that you are sure you'll have time to come back to that. The order of the way the format that the ABO wants you to answer the case in is pretty much the same for every case, which is they want you to describe the image, take a history, do your exam, what's your differential diagnosis, how would you work this up, what you think the actual diagnosis is, management, and then follow-up and patient education. So that needs to be just drilled into your head. Study buddy is a very helpful thing to have. You can find, if you have a friend who's taking the exam at the same time, that's a really nice resource to have. It forces you to speak out loud and, give each other feedback. You can even have a non-ophthalmologist friend listen to you. They won't be able to grade you on the content, but at least it forces you to speak out loud to someone, which is good practice. In general, when you're timing yourself, set a goal that's shorter than the time that you actually have to answer the question so that you can avoid over speaking and give yourself some buffer room. And then we'll talk about this a little bit later on, but we actually have an OphthoGenie community online now where you can post to find a study buddy for somebody who's taking the exam at the same time as you. Recording yourself is helpful. Listening to your recordings is helpful, whether they're bad or good. If you sound horrible, you want to know that. And then if you have recordings that you feel like you did a good job, listen to those over again so you can, remind yourself, how you're supposed to sound when you're confidently and succinctly answering these questions. One of our users said that she created flashcards of high yield information to review on the go. You can do that as well. She also found Google Images to be helpful just to review images of different, different presentations of diseases. Just be aware that on the actual boards, the quality varies and they may not be classic presentations of diseases. So we'll talk a little bit about OphthoGenie. So, as Kendra mentioned, we started OphthoGenie when a kind of an early version of OphthoGenie when we ourselves were studying and felt like the material wasn't really adequate. And we wanted to create something that was more than just the content. We wanted to teach people how to actually get through the format of the exam. So right now we have 200 interactive cases that teach you how to work through the case in the in the 8 elements that the ABO wants you to structure your responses in. The grading is broken down into the 3 criteria Kendra discussed, which is how you're graded: data acquisition, diagnosis, and management. And you can take an unlimited number of tests, and you can reset your data once, which we recommend doing later on when you're closer to the exam, so you can kind of see how you're doing once you've had time to study. So I'll show you some of these features later if you guys want to see them, but we have performance analytics where you can see how you're doing on each topic and in each grading criteria. We have 2 different testing modes, beginner and advanced, depending on where you are in your studies. Beginner mode is not timed and it gives you prompts of the kind of 8 elements to help you structure your answer. Advanced mode is timed and it doesn't have any prompts, so that's the most exam-like. And you can take the tests in either a single topic or paired topics, which is how the actual exam is administered. And then, as I mentioned, we have the timing feature. We have the study bank, which is the same cases that the testing feature has, but it's presented in a different format where you can pick select a specific case that you want to review. And this is helpful early on when you don't really know what to study yet, or later on when you're trying to return to a specific case to review. And then we mentioned getting a study buddy. OphthoGenie actually has a study buddy feature, which we actually created before the pandemic, but now it's more relevant because this is how the actual exam is administered virtually now. And so it really mimics how the actual exam is administered. So your screen will show the case only, and your examiner or your study buddy's screen will show the case and the answers. And they don't have to be an OphthoGenie subscriber, and so they can kind of be your examiner to help you study. All right, and then the last thing is we wanted to announce our new OphthoGenie community. We wanted to create a place where you guys could come together and ask questions about oral boards to each other, or about OphthoGenie, or to post to find a study buddy. So we just launched this, and this is the link and the invite code, and there's a QR code here too if you want. We're also going to email this slide deck after the the webinar, so you guys will have this too. But this is a good way for you to kind of be in touch with other people who are taking the exam at the same time as you, if you have questions or, and we're also posting announcements on here as well for OphthoGenie. And this is a little quick tutorial on how you can actually save this icon on your phone so that you can kind of easily access the community as well. All right, so I'm going to show you guys a demo here quickly. And if you guys have any questions in the, please write them in the chat. We did get a few questions in advance that we're going to answer as well after I show you guys this demo here.
And so he'll put the link in the chat box as well to the community there. So you guys can see that with the invite code join OG.
All right, can you guys see my screen here?
Yep.
So this is the dashboard for OphthoGenie. So you can see this is your, I'm just gonna refresh this for a second here. So, and actually, yeah, we have our, you can see at the top of your dashboard, there's the link to the new community. So you can click on that to join. So you can see this is my test data here, broken down into the 3 categories. If you scroll down, you can see my score, my scores in the different topics in tabular form. And then you can see tests I've taken in the past and cases that I have favorited. And then up here, you can look at old tests. You can review the study bank, which, as I mentioned before, is the catalog of cases. If you want to pick a specific case to review, you can do that here. And then this is our testing feature, which is the main, way this is used. So as I mentioned before, we have beginner mode and advanced mode. And then you can click if you want to choose one of the 6 topics, or you can choose pair topics, which is how the actual exam is administered. And you can choose the number of cases you want to do. 14 is what is actually administered in the exam. So if you were trying to do like a mock test, you would choose 14. I'm going to just do 2. And then here you can see this is the option to enable the study buddy feature if you are going to be using a study buddy. And then we can begin testing. And so now this is in beginner mode. So you'll see on the right-hand side, you do have prompts. So here you get the question stem at the top and then the image. So on the actual exam, this is what you're given, what you're seeing on the left-hand side of the screen. You're not given these prompts on the right, but this is beginner mode. So it's trying to help you like, okay, you're supposed to be describing the photo now. So looking at this color photograph, my attention is drawn to, and then the answer is hidden. So this is meant to force you to speak out loud to test yourself. And then, you're kind of grading yourself. It is a little subjective. There's not a great objective way to do this. We get questions about how harshly to grade yourself. In general, if you feel like you got the gist of it and the important things, then give yourself credit for it. Like in this case, if you left out like macular edema or something, like that's, you got pretty much everything. So I would click yes. And then the next moves you on to the next prompt. I would take a complete history focusing on you speak out loud, test yourself, and then reveal the answer. Again, this is beginner mode with the prompts. When you're in advanced mode, you won't see any of the prompts. And so I'm just gonna reveal all so we can just go through it. So then you can see there's the exam, your differential, your workup, your most likely diagnosis, what you would recommend for treatment, and then patient education. We also get questions on, we made this very thorough on purpose. You are not expected to say every single thing that's on here. We wanted it to be thorough so you would have all the information. But again, if you have kind of the gist of things, give yourself credit for it. Like for example, in this, if you forget to check antiphospholipid antibodies or, it's that don't be too harsh because they generally, we don't know exactly how they grade things, but they're not that nitpicky about things. Like if you get the gist of it, they will give you credit for it. So then I'm just gonna mark that I got all this right so we can move on to the next case. And then basically you can go through that as well. I'm just gonna exit out of this. And then I also wanted to show you just what the Study Buddy screen looks like. Can you guys see this? Kendra, can you see the
Yep.
Study Buddy screen? Okay, so basically, just ignore this. This is an old, this is an old video I made, but basically, I'm just showing you on the left here is what you would see as the test taker, and on the right, this is what your study buddy would see as the person who's your examiner and who's grading you. So, and it's kind of synced in real time so that as the examiner progresses you through the cases, your screen will update. And let's see. So I think that's everything I wanted to show you. Did you guys have if you want see anything specific, put it in the chat.
Mhm.
Kendra, maybe we can answer the questions we
Yeah.
got. Yes.
Yeah, we got a couple questions, and we can answer those certainly. If you guys have any more questions, like Nora said, just probably the easiest is to type it into the chat box. Um, so we have one question is each individual case graded as pass fail, or is there a score that is used and totaled across all cases to determine overall passing? So the short answer is we don't know. They don't really tell you exactly how the grading's done, but that is on that compensatory model so that you can do poorly in one case, and if you do well in other cases, that can kind of make up for that, as long as overall you kind of meet that kind of passing standard, which is, the ability to kind of manage cases in those scenarios. So I hope that answers. Nora, do you have anything to add to that?
No, I think, yeah, we don't know exactly. They're not very open about exactly how they grade it, but yeah, I agree with what you said.
Another person asked, what is the best way to use OphthoGenie from now until the exam? And they have a 2-month span. So if you're taking it, in June, you could say, okay, week 1, and this is just an idea, you can really use it however you think it's best for you, but week 1 could be like a study bank review. Week 2 and 3, you could use the beginner mode cases so that you kind of get into the habit of answering questions in that pre-specified kind of format that the ABO wants you to touch upon. And then once you kind of have that under where you're just kind of, going through the cases and you more or less have the structure memorized, you can use weeks 4 and 5 to do advanced mode cases. And then you can take the remaining 3 weeks to reset the data. So we allow that to happen. Once you can kind of reset all of your data and then go through advanced mode cases just as many times as you can. And you can also favorite cases. So if there are ones that you either think are very high yield, or are very likely to come up, or you need to work on, you can kind of star and return to those as well. Anything to add, Nora?
No, I think that pretty much, I agree, sums it up. Um,
Uh,
we had one more question. Oh, let's do the last question we got on online. So somebody had said, any recommendations for choosing a place to take the virtual exam, guest room, library, etc. I would say I wouldn't trust a library. Like I would be worried even if you like reserved a room that somebody would interrupt you. I would make sure that you're 100% not going to be disturbed. Um, and you want to make sure that you obviously have a fast, reliable internet. You can't have a virtual background. So just you have to kind of make sure you have somewhere and again, like they said, that you can't have any like insignias or study material or anything like that around. So I mean, it depends on I feel like I personally would feel safest taking it at home because it's the most controlled. I feel like environment I have the most control over. Um, what do you think, Kendra?
yeah, I would say unless you have 2 toddlers like me, it would probably be the most controlled space, but whatever you think is the most, or if you have like a private office somewhere or something like that, somewhere where the internet's reliable. Um, that would definitely be, I think the internet reliability is the main thing. There are different ways that you can actually conduct tests of your internet speed as well. So just make sure that you're kind of well set up for that and that you don't have your cell phone or anything else that might go off. And the last question was someone, before we get to Aaron Lanzos, hi Aaron, what timing should we aim for each case? So we were saying there's about 50 minutes for 14 cases, 50 minutes for 14 cases in a room. So about 3.5 minutes per case. And there may be, you want to leave some time for transitioning between cases and what have you. So try to keep it around under 3.5 minutes, I would say. So Aaron's asking, the structure of an answer, I'm sorry, seems different for some optics cases. For instance, how does this device work? Some different questions she's seen. Can you speak to this a bit? So definitely the optics structure is different, and even within OphthoGenie, our answer structures are different, I would say. The optics do tend to be clinically focused on the exam. So I didn't have, and I don't think it's changed. I didn't have any, pictures of devices like what is this or anything like that. The optics topics were integrated into like clinical scenarios. So like a post-op patient or a patient's unhappy with their glasses. So it still is very clinically structured, but you will have to kind of you may have to walk through it a little bit differently. It's not going to be so much like, maybe you won't get any, but you can still kind of apply it, I would say. Like you could have a differential of what you think might be going on. In general, I think it applies, but you might have to just kind of condense it a little bit.
Yeah, I agree. The optics cases are kind of weird because it's not in the exact same format that the other cases are in. And so I agree, like Kendra said, they do like the clinically oriented ones. So, and optics and anterior segment are combined in the same room. And so they tend to like to combine it with something anterior segment. Or it can just be something like Kendra said, a patient's unhappy with their glasses. I feel like the anterior segment stuff is like, a patient had cataract surgery and had a hyperopic surprise, like what happened or something. And then you kind of have to, again, it's not the same like image description, history, physical, differential, but you can kind of use that outline a little bit, right? You can say, well, I mean, that one's kind of hard to really take a history, but you could ask like, did the patient have a history of LASIK? Were they nearsighted or farsighted before that? And you can, the exam, like I would make sure the lens is in the bag, and like there you can kind of still use that outline, and these are the possible things that are going on, so you can still use the outline a little bit, but it is a little bit different. But again, they love like tying these like optics principles into clinical scenarios.
Mhm. Um, Another question, sure. Another question, Teresa. Hi, Teresa. Okay, some Tufts people, alum in here. So is there a minimal number of differential diagnoses that you should list, especially for a very obvious diagnosis? I would say yes. I don't have a magic number. We tend to do three. Just your top three, and then your most likely, top 3 or 4, I think is reasonable. Even if it's very obvious, when people ask this question, this comes up when we do these webinars. I think even if it seems obvious, you should list some things that you could say, even say it's, I don't know, I'm trying to think of one uh, like a corneal ulcer or something like that. And you could say what you most likely think it is. And I listed it in order when I did it. So I would say highest on my differential is, whatever. Um, I would also consider X, Y, and Z. And like to you, it's obviously probably not it, but you should let the examiner know that you're thinking about those things. The other things that I would list out, verbally is things that you don't want to miss. So, um, it's a central retinal artery occlusion or branch retinal artery occlusion. You'd want to make sure that you said it's not, I would want to make sure it's not giant cell arteritis. Anything that's like vision threatening or life threatening, you want to make sure that you've kind of ruled out. A white reflex is another one. I think, if it's like leukocoria, you can give your differential. And just things that you would want to, even if you're strongly kind of leaning towards one thing, you might want to put that highest on the differential, but then you'd want to say, I'd also want to rule out X, Y, or Z because those are, things you don't want to miss.
Yeah, I agree. Even when it's obvious, you still need to list a differential. But I mean, they know that you know what it is. Like if it's
Yeah.
like a retinal tear, you can be like, I think this is most likely a retinal tear. My differential also includes retinal hemorrhage, vitreoretinal tuft, retinal detachment, something like that. But like
Yeah.
you can say this is most likely a retinal tear, and then you just keep going. They just want to hear some other things it could possibly be.
And then when you're doing your exam, like if you are shown something, then you'd say, I would pay, particular attention. I'd do a dilated fundus exam and look for pigment in the anterior vitreous. I would do a scleral depress exam. And then you can focus your, kind of the rest of your exam to kind of support your case, I guess.
We got another question. Do they prefer differential after you describe the image, how Pemberton seems to be structured, or after questions, exam, obtaining workup, or is it not a big deal? So when we took the exam and when we first created OphthoGenie, the way they had it structured was image description followed immediately by differential diagnosis, but they changed that a couple years ago. I don't think it has changed back to my understanding, but you can always double check on their website. But the way they want it now is how we have it on OphthoGenie, which is image description, history, physical, differential, and then workup. So the differential was before the workup, and then your workup is kind of like how kind of how am I distinguishing between the things on this differential? Like what workup am I going to do that's going to help me figure out what the actual diagnosis is? And again, this is all there, this is all generalized, recommendations of how they want it. Your individual examiner may steer you
Mhm.
differently. So you just need to follow their lead. I had some examiners that were kind of like interrupting me and just like move like and just be like, okay, how would you treat it? And like I skipped like 60% of my spiel.
Yeah.
And I think sometimes they do that if they get the sense that you know what it is and they're trying to save you time. Sometimes they will redirect you if you're going down the wrong path. So, this
Mhm.
outline is assuming that you are not being interrupted or
Right.
redirected. If you are being redirected, just follow the lead of the examiner.
Yeah, exactly. 100%. I agree. Like, and you just have to have it in your mind, the structure and exactly what you're going to say, because you may, and I had, like more than one examiner that didn't say anything. So I just was like, okay, here we go, and just went through it all myself. But if they are kind of jumping you ahead, it's because they're trying to move you along or, help you with the timing.
You also, like, I had an examiner that I went through the whole case, like beginning to end, and then at the end they just go, anything else? And I was like, about what? I just talked for like 2.5 minutes straight.
Mhm.
So, and you can't really ask them questions, so you just have to start answering, and they may kind of direct you and give you more information, but you just kind of have to go with their lead. You can skip a case, like I mean, sometimes they will just also move on if they feel like you're just killing time and not getting anywhere, but you can also ask to move on, but they, I don't think they will let you go back to that case. So it's kind of, if you just feel like I'm stuck on case 4 and I'm not going to get through the rest of this room, then you should just move on.
Mhm. Is there a timer in the room available for us to see? Not to my knowledge, there isn't.
Yeah,
Uh,
when we took it in person, there
Mhm.
was no timer. I don't think they let you see it on the
I don't
in-
think so.
um so I mean that's part of the reason doing more cases is helpful because you'll get a sense of how long
Hmm.
it's to talk through. Like if you've timed yourself on enough of these cases, you'll know like, oh my God, this is taking a long time. Like you'll get a sense of how long 3.5 minutes is.
Yeah, and the OphthoGenie app, like it'll time you and you can look actually if you go back, you can see what like average time you spent on your cases and stuff like that to see if you're in the ballpark. And you may have some cases that are longer. There's going to be more talking involved, and then you might have more straightforward ones. So as long as you're in the general ballpark of that, like under 3.5 minutes, you have a little bit of leeway there.
And actually, I feel like I sound like an old person. When we took it, it was different number of cases and different number of rooms,
Hmm.
but it was 2.5 minutes a case, and that was
Hmm. Yeah.
yeah. I mean, 3.5 still isn't a lot, but you have to learn how to talk fast and succinctly.
Any other last minute questions here before we wrap up?
Also, Kendra and I can stay on for a little bit if anybody has any other questions, or if you guys want to see a demo of something specifically, we'll stay on for a few minutes extra if you
Mhm.
guys want. And then, oh, we also actually had one other question for you guys, some feedback we were hoping for,
Oh,
if you
yeah.
want to write in the chat. We're always trying to find ways to make OphthoGenie more useful for you guys. One thing we were thinking of doing was creating an app, like a mobile app on your phone to either actually go through cases on your phone, or we were also thinking of doing like a flashcard app where you can just kind of like flip through flashcards like high yield stuff kind of quickly on your phone. So we just wanted to take a poll of if either of those things would be useful. So if you guys want, just write in the chat if you think either of those things and which of those two would be useful. We would appreciate it.
Yeah. And when you
And
guys are thinking about that, oh, good. Let's see. Flashcard app sounds useful. Yes.
we also got one more question here. If there are any key history items or workup needed for diagnosis, will they provide that to us? So they may, so you have to ask for it.
Mhm.
So let's say somebody comes in with like bilateral disc edema or something, and you order a vision and you're like, I would get a visual field. They may show you then a picture of the visual field and have you interpret it. And then, obviously that can kind of help steer you towards the diagnosis. They won't just show it to you without you asking for it or ordering it. And then in OphthoGenie, we also have that kind of built into some of the questions where some of the cases you'll see it says additional information will be provided after the workup. And so then sometimes, like you'll ask for, like MRI or
Mhm.
OCT or something like that. And then as you advance through the case, that will pop up and then you'll kind of move on from there.
Yeah, I think I had some MRI, I would get neuroimaging and then they show you the MRI and kind of go from there, or OCT, something like that.
All
Great.
right, thanks for you guys who have written about the feedback. Feel free to uh, keep writing questions or feedback, and we'll stay on. If you guys feel free to go whenever you want. We don't want to keep you
Mhm.
long, but we'll stay on to keep answering questions. Do you have to be specific about the antibiotics? Um, I mean, I'm assuming you're talking about like a specific type of antibiotic when you're recommending treatment. I don't know if you have to say exactly the antibiotic. You might want to have an idea of like, broad spectrum, gram positive,
Mhm.
gram negative. If you know specifics that would be good for it, I would mention that. I
Mhm.
I I probably would know more than just like antibiotics.
Yeah,
I think that's not going to be specific enough for them.
right. Same with drops, like what kind of drops you'd use or
Yeah.
intravitreals, everything like that.
One other question, this just reminded me, one other question we get a lot, is if you can refer to specialists. So on the way the ABO wants you to approach this exam is that you are basically everything from like a low vision optometrist to like a retina or oculoplastic surgeon
Mhm.
or pediatric ophthalmic surgeon. Like like for example, if it's like a peds case and it's like a strabismus case and they need like strabismus surgery, like a bilateral, medial rectus recession or something, you would say, I would do a bilateral medial rectus recession. You wouldn't say, I would refer to a pediatric surgeon, even though in real life you don't do that. That's, like I'm a medical retina person. I don't do that, but like that's how you answer the question. Same for like retinal detachment repairs or oculoplastic surgeries. Like you answer as though you are the person doing it. If it's something like, let's say they have, you're worried that they have a malignancy and you want them to have a metastatic workup, then you can say, I would work with their oncologist to, have a metastatic workup, including, whatever, like CT, chest, abdomen, pelvis, or whatever, PET scan, whatever you're doing. So you can say, I would work with the oncologist if it's a specialty outside of eye care, basically. But if it's within eye care, then you need to be able to say how you would handle it.
Yeah, it's basically like a guideline would be like anything that's covered in the BCSC is fair game. So if it goes into, I know we had a question before about like, do you have to know in detail how you do like repair an RD? Like, not necessarily all of the details, but I would probably have an idea, if you would, you at least have some knowledge about like if this person's like young and phakic, if you do a buckle or if it's a redetachment or something like that, like consider silicone oil. Um, if it's kind of talked about in the BCSC, I think that they can ask it. Someone asked, can you speak in abbreviations or do all words have to be in full form? This goes for diagnostic testing or abbreviations in the differential diagnosis. I would say I mean, in general, I think you could say like MRI, OCT, you know, um,
I think abbreviations are
that's
fine.
fine.
And we use them so much in ophthalmology. Honestly,
Mhm.
like I feel like you would sound like an alien if you did not talk in acronyms in ophthalmology. Like I would get an optical coherence tomography of the macula.
Right.
I think if they want you to, if it's something like weird, maybe they'll ask you to define it. I think that's like the
Mhm.
worst case scenario. But
Yeah, I think in the differential, maybe I would say it, I'm trying to think of one that would be,
like a CRPO or CRAO, you might say like central reference.
yeah. Yeah,
But
I don't think it's that big of a deal, but
again, I think worst case scenario, they would just say, like, can you
mhm.
define that or something? And but I doubt that. I think it's just so common in ophthalmology
Yeah.
that it's pretty clear.
Okay, and Jamie's asking, I know you already spoke on this, but just to check, the review books all seem to have the differential instead of history physical after you describe the picture. Do you think saying a differential before history physical will cause you to miss points? No, I don't think that doing one, I don't think either way it's going to matter as long as you hit the points you need to hit. Um, and it may and there's no way of telling like if one examiner prefers this versus the other. I honestly would have to go back and see if they, Nora, do they say on their website if they, I would have to go back and look and see if they actually give the recommendation. That's kind of, I defer to the ABO website. Oh, the ABO website shows history physical first. Yeah, I mean, I think I would,
I'm looking at the website now. It's history
yeah,
physical first and then differential.
differential.
I think that's part of like what's nice about the online resources
Yeah,
that we can update them faster than the books. Like I
right.
said, when we started OphthoGenie, we had it the other way because that's how the
Yeah.
ABO wanted it, and then they switched it. So we switched the order of all of our cases. So yeah, I'm looking up a sample case right now on their website, and they have history, physical, and then differential.
So yeah, I would try to do it that way, but I don't think if you started down the path and then you're like, oh my God, I'm doing this out of order. Just it's fine. Keep going. I think as long as you hit the main points, and if there's something crucial that they really want you to know, they'll ask you. I have been practicing the other way, so just checking. Yeah, I think, um, I would try to do it the way that they recommend, but
Yeah, just, I mean, I would triple check on their website and just make sure that's like how they have it on the ABO, because ultimately, like that's the
yeah.
best resource for what they're looking for.
Mhm.
And yeah, to just make sure that that's
Mhm.
still what they want.
You're welcome. Great. Well, that's almost 9 o'clock. I mean, I hope we've answered some of your questions, and just shoot us an email if anything comes up, about boards, OphthoGenie, whatever. It's a stressful test. We remember it well. So, uh,
Yeah, so you
just
can email us at, yeah, support@ophtogenie.com, or
Mhm.
join the that new community we have, and you can also
Yeah.
post questions. I mean, we look at those and answer, we'll answer questions. Your colleagues who are taking the
Mhm.
exam, you guys can chat about things too, any other questions.
Yeah, you
Or
guys probably are aware of more stuff than we are now being out of it. So it's probably going to be a great place to get resources too from each other. So, all right. And just keep talking out loud. Keep timing yourself and talking out loud. It's super awkward, but you'll thank yourself for it.
yes, agreed.
Well, have a great night. Thanks for joining us and good luck.
Yeah, you're welcome, guys. Thanks for joining.